Very excited to have everyone here learning from Dr. Ali Rezaie. My co-host is Dr. Allison Siebecker. I'm Shivan Sarna. Hello, hello, hello all around, and wishing you all the best of health. So before I get to Dr. Rezaie, I'm going to just explain who Dr. Allison Siebecker is. She is a award-winning, world-renowned SIBO specialist. She has helped thousands of patients resolve their SIBO through both clinical practice and also her course, SIBO Recovery Roadmap. And then she has trained so many incredible professionals with the SIBO Pro course. On and on and on. Her website, SIBO Info, go there now. Well, watch this first. I have SIBO SOS, and we co-created the SIBO Recovery Roadmap course together, and I've written the book, Healing SIBO. We have tons of free resources, SIBO SOS. Thank you. Now, Dr. Ali Rezaie. Dr. Rezaie works in California at Cedars-Sinai, and I know that everyone's going to want to go see him after this discussion, so we'll find out if he's taking patients. He is the director of bioinformatics and biotechnology at the MASS program, the Medically Associated Science and Technology program. You hear us talk about him all the time when we are also talking about his partner in healing, Dr. Mark Pimentel. This is a very special opportunity right now to learn about the research that they're doing that was revealed at DDW, Digestive Disease Week 2025, and we have lots of questions for him, and we really appreciate you being here, sir. Hello.
Hello. Thanks for having me.
So glad you're here.
We love it. Our audience loves you and learning from you, and it's so hopeful, right? So there's lots and lots of hope. We're very impatient patients, Dr. Rezaie. So help us to stand the ground and to remain hopeful until those treatments are 100%. And I know you're working on them diligently. Dr. Siebecker, I'm going to hand things over to you so you can get us started with some of your questions.
Okay, great. Well, I just want to start with asking about the IBS SMART test. So this is the test that can help us understand about if SIBO has been caused by food poisoning. But I get a lot of questions about this test. I want to ask you, one of the questions a lot of people have is how long after food poisoning is the IBS test SMART valid for? Like, for instance, if somebody had food poisoning 40 years previous, they still have, IBS and SIBO, they have the symptoms. Would this test be valid?
That's a great question. So IBS SMART has two components. One is anti-CDTB, one is anti-vinculin. So when you get a food poisoning with a gram-negative bacilli, and that's a mouthful of word, but they are the most common things that you hear all the time. Campylobacter, Salmonella, E. coli, Shigella. These are the most common causes of food poisoning and traveler's diarrhea. So they have a protein called cytolethal distending toxin, so CDT, right? Again, the name is unimportant. That's why I stick with CDT. And CDT has three components, A, B, and C. So it's a 3D structure sort of protein. And when we get that infection, we develop antibody against this protein that some of these bacteria have. Right? So we develop anti-CDTB. And that's nothing unusual. We develop antibodies towards infections all the time. The classic example is COVID, right? So when you get COVID, obviously you develop antibodies against COVID. That's why the next round that you get the infection, it's less severe because your antibodies are sitting there and waiting to help you. Now, this antibody, if you just let it go and you're not exposed to that bacteria again, slowly your body forgets about it. How does that happen? We have some cells in our body called lymphocytes, and these lymphocytes are involved in fighting viruses, bacteria, but some of them are called B lymphocytes, and they produce antibodies, right? And these antibodies have some memory, right? And if they're not exposed to that antigen, slowly they forget about that antibody and they don't produce it. And that's why, for example, when we give vaccines, you have to get a booster to wake it up and give them. I was like, oh, wake up, remember about this? I was like, oh yeah, I remember. Okay, let me just make more antibodies about that, right? So anti-CDTB, if you have only one infection, it's going to peak slowly and go down, and eventually your body forgets about it and it goes down to normal sort of levels. Not completely normal, slightly elevated still, but that will peak and come down. So the exact timeline is not clear, and it's differs between each individual, but somewhere between 6 months all the way to 3 years, slows to normalize, right? But the second antibody is called anti-vinculin antibody. So vinculin is a protein in our body that structurally looks similar to the CDTB. So these two proteins look similar. So your body confuses this protein as this and starts attacking this and developing antibodies against vinculin. So you start having anti-vinculin. So the problem with that is that now vinculin is always there. So these memory cells are always being exposed to those protein. And they know, okay, it's still here, so I better start continuing to produce antibody against it. These are called autoantibodies. Why are they called autoantibodies? Because you're producing antibody against the protein that exists inside of you, right? And that's why the word autoimmune, right? So essentially you're going against yourself. So now, because antivinculin continues to stay high because your body is exposed to it, that one stays high. Your infection may be 40 years ago, and you developed anti-CDTB, and the peak is long gone, but antivinculin can stay up almost forever, right? So their peaks are very different. So to answer your question, in terms of CDTB, if the infection is 20 years ago, it's probably not accurate, or it can be falsely low, or it is truly low, but it's not going to, because you have already missed the peak. But the antivinculin, if it's positive, yes, it's already there. So it covers both immediate reaction and also late and even way remote reaction to these infections.
Thank you. Very good explanation. Another part of that people often ask is, have you ever seen an IBS Smart test turn negative? And when people are asking this, not specifying which of the two antibodies. And if you have ever seen it turn negative, was there a certain treatment that worked to get it negative?
Yes, so that's one thing that is in the works. And we actually just published in Digestive Disease and Sciences about looking at the trends. We see that anti-CDTB, unless you get an infection, it can go down by itself because you're not exposed to that. That's why we, for patients who do get food poisoning and they have now IBS symptoms, we tell them to be very vigilant about what they eat and also when they travel to take precautions for not getting an infection. Right now, these precautions can be taking bismuth or Pepto-Bismol that is known to be protective against travelers' diarrhea. Anecdotally, a small dose of rifaximin has been used as well. So half a tablet of rifaximin or Xifaxan with each meal decreases the chance of getting food poisoning. Because remember, these memory cells, the minute they get a booster exposure again, now they produce like a lot of antibodies and everything just renews. And we know that that happens based on the data that we have from veterans. US veterans who went to Afghanistan or Iraq and they were redeployed, those who had infection or food poisoning in the first deployment had 4 times higher risk of getting another infection on redeployment. Essentially, if you have food poisoning, you become more prone to get another food poisoning. And we think that's an evolutionary thing with these bacteria. Essentially, they prime your body as a great vector for them to constantly attack and multiply and get out, right? So that's one thing that they do, not just to us, they do it to all other animals as well. It's very important not to get an infection so it doesn't peak. And also in terms of vinculin, that's way tougher, right? Because now that's almost an autoimmune reaction. So have we seen other antibody-driven autoimmune disorders somehow getting better by themselves? Yes, it is possible. A spontaneous sort of improvement has been seen. But that's usually where the science comes in, trying to clear these antibodies out to see if patients get better. Now, in extreme cases, when patient has chronic intestinal pseudo-obstruction and all, for example, IVIG treatments and that type of treatment to clear out the antibodies has been done. Obviously, that's not an easy thing to do in a large population. So that can be taken out. But remember, in dose intervention, such as plasmapheresis or IVIG, the minute you stop that treatment, those memory cells are there. They produce it again, right? So that's what's tricky. So immunosuppressive therapy and all that. And our lab is actively working, now it's at the mouse and rat stage, to develop antibodies. These are some similar to monoclonal antibodies that they go and specifically take this out, right? Because one of the problems is that you can't just go out there and take all the antibodies out, right? Then that will make you prone to all the infections. All of a sudden you can get measles, right? So because now you don't have memory to fight against those infections, right? So you have to be preferably very specific and trying to snipe out those specific antibodies. So it's easier said than done, but at the mouse level, at least, it looks promising.
Yeah, I know that this is one of the main things your lab and your team's been working on is to find a cure for this. So thank you. Okay, and then just two more questions on this. People get confused about the interpretation when one antibody is positive and the other isn't. Like, for instance, if it's just CDTV that's positive and not vinculin, people think, well, then there's no autoimmunity, right? And really, did this even really cause their SIBO? Will they just get better? That sort of thing can confuse people. Can you comment on this?
Yeah, absolutely. I mean, it's kind of naive to think that these are the only two antibodies out there doing this, right? So anti-CDTV is telling you that, yes, you have had exposure in the past to an infection, right? And that infection, that cascade that we've described, is one of them is vinculin, right? So, and that's a classic one that we have discovered. But probably there are other pathways that they can cause long-term reactions and autoimmune reactions that yet to be discovered. We're looking for it, but you know, the science of antibodies is drastically improving every year. Like thousands of new antibodies are being found every year. So that's so one possibility is that there's a subgroup that it's not driven by the antivinculin. There's another guy that is driving this, and we need to find that. So that's one possibility. But again, having a positive test event shouldn't stop you from looking at in other causes doing this. Because somebody who has these antibodies doesn't necessarily mean that you don't have, for example, whatever drug-induced dysmotility, right? Doesn't make you immune of other causes. You have to keep your differential always open and keep an open mind of that multiple causal influential factors can be present causing all this together. Yeah.
Such a good point. We see that really commonly. I mean, I see that really commonly. This test is positive and there's several other causes, you know, like all at the same time. Okay, last question on this topic. A lot of people have, and it's basically like if someone is traveling or whatever, they go out to eat, they get food poisoning. What would be the recommendation of treatment to prevent them getting SIBO? Like, what can they do?
Yeah, so that's a $1 million question. So the good news is that the majority of people won't get it, won't get SIBO, right? So the majority, you just so your body takes care of that infection and it goes away. What can prevent it? I don't have a clear answer for you. What we can stop sort of patients to get that? Because remember, if 100 subjects or patients get infection, food poisoning, only 11 of them will end up having IBS-like symptoms and possibly SIBO or EMO and dysbiosis, right? So 89 people won't get it. And probably those 89 people are not doing anything differently than the other 11, right? It's the underlying genetic predisposition and maybe medications, maybe the structural abnormalities of the gut, right? So it's really hard to come up with something that at that point to stop SIBO from sort of developing at that point. In fact, there was a study many years ago that was done in England. Not as specifically, this was before the discovery actually of antivinculin and anti-CDTB, that patients who got food poisoning, they put them on steroids right after to see if they can stop post-infectious IBS or see if post-infectious IBS gets better if it's immediate. And it actually didn't work out. But it was interesting that it was on people's minds that, okay, can I stop this by suppressing the immunity to attack itself during this process? And that didn't work. But I'm not aware of anybody else taking on that approach yet to see, okay, at that point, what do we do? Because
Okay,
it's kind of like a tough topic to target, right? Because 89% of people won't have any problems after that infection. So I'm like, why am I treating everybody to see if all of a sudden that limit? It would be very tough study to do.
Right.
yeah. Okay, let's move on to the DDW studies you all put out, and there were some really exciting ones about treatment. And one of the really exciting ones was this new molecule CS06 that had remarkable, seemingly, benefits in reducing methane. And if you'd just be willing to comment on it, would love to hear.
No, absolutely. CS06, well, I mean, at the beginning when you develop a molecule, you have to put a name on it so you don't repeat that giant sort of name because it's essentially it's really hard. It's an MTD blocker, which is the enzyme within the archaea, the methane-producing microorganisms that produce a methane, right? And this molecule goes and blocks that. So what we showed in this study is that we had rats, and we have worked with rats with models of methane production in rats for a long time. So we can make the rats with a high-fat diet to produce more and more methane. And we checked whether this molecule can decrease the amount of methane production. And interesting enough, we saw that it actually does decrease methane production. And not just that, also improve the symptoms. Because we check, for example, in these rats, how often they're pooping, how much water is in the poop, and that they all improved. And more importantly, we looked at specifically whether this just suppresses methane production, which also suppresses and decreases the number of methane-producing archaea, which turned out it does. Mainly is probably it suppresses their metabolism and not completely wipe them out, but they decreases their number. And that is a very promising. So this potentially, when hopefully eventually we will move to the human sort of stage, and that's what we're aiming for. Considering that this is not absorbable, hopefully it will work intraluminally, because that's the most elegant way of treating this this disease, right? So, but just affecting the gut and nowhere else. So we decrease the side effects, right? Because you don't know whether this enzymes all of a sudden exists somewhere else in our body, and all of a sudden you're blocking it and causing harm. So you want to keep it within the lumen. But within the animals, which interesting enough do harbor very similar methane-producing archaea in their gut. it's working really well. So that was very promising, and that's what we reported at DDW, and it's very exciting news.
It's very, very exciting. I mean, I was just thrilled. I like texted Shivan as soon as I read. I was like, oh my God. Because, I mean, like we just look forward. Obviously, it's going to be some years before this could come, goes to human trials, and then can it come to market. But just to know that this is in the pipeline, so many people could get so much relief. And also this isn't specifically an antibiotic. It's an enzyme blocker, as you mentioned.
Right.
That's very appealing to many people. And I know, it's very early days, but I mean, it was like it brought methane down by up to 71%, in one subject within 4 hours. And then, in 24 hours, it went to 0, so there's like people, we could only dream of such a thing, who suffer from terrible methane causing them constipation and all these symptoms. Yeah, Shivan.
Okay. So do you think it'll be expensive? Is it
It all depends. That's how many sort of hoops that you have to go through to get it approved, and also at this point it's being made for animals, right? How much? Because making enzymes and all, it's not cheap, but how much you can make it cheaper in mass production at this point, I don't know, but technology is improving. So enzymatic blocking sort of agents are getting cheaper and cheaper and cheaper because the technology is improving in that field. The answer is that I have no idea, but
okay, but you're not like overly worried about like, I'm just worried that it's going to be so expensive. So
yeah, it's not going to be like a monoclonal antibody that is going to, it's guaranteed it's going to be expensive. No, enzyme blockers shouldn't be that super expensive. Yeah.
Okay. And then just to circle back on one thing, you said that of these 11 people who would potentially get SIBO out of 100 after food poisoning, you talked about the genetic predisposition. Have you all identified any SNPs that you see being a predisposed genetic condition?
That's a very good question. So whenever these epidemics happen, so it's, and that is well controlled and well documented, it usually happens in a village of 300 that you can go in and study everybody and all. But unfortunately, a village of 300 is not enough to figure out SNPs, right?
I got it.
That's so very good question. As of now, there is no specific sort of genetic mutation that has been linked to this. Although there are some genes that have been associated with IBS and development of IBS, but they have been too non-specific to be, number one, be a target, number two, being a major pathophysiologic sort of approach. But there is no question that now that we know that this is in part autoimmune, that all autoimmune disorders have a genetic predisposition behind them, right? So, and that's a known fact. Now, a lot of even well documented and well established autoimmune disorders, we're still failing to find that exact SNP or constellation of SNPs that cause it. But there is a genetic predisposition to it. So that's not surprising.
Okay, thank you. Back to you, Dr. Siebecker.
Okay, well, of course, I wanted to bring up your newest elemental diet study. And it looked like this one focused mostly on methane and intestinal methanogen overgrowth. I got that right. And it looked like it was just another very successful study. So any comments you want to make about this one?
Yeah, so I mean, just to go back, this was the elemental diet this was the palatable elemental diet clinical trial that we did on 30 subjects. Just to give you a little bit of a study design, is that patients underwent 7 days of screening. During that 7 days of screening, patients filled out daily diaries, took pictures of their poop throughout the whole study, and also gave us samples. Now we took blood, we took saliva, we took urine, we took like breath VOCs, and also stool. Now we are analyzing all these as we go along. There was like so we took a lot of biologic samples, and then patients were treated with 2 weeks of elemental diet and exclusive. They couldn't drink any other drinks or eat anything else. A little bit of a black coffee and a little bit of a black tea were allowed, and drinking water is okay.
And this was mBiota, right?
Yes, this was mBiota. And then after the mBiota was finished after 2 weeks, then we followed the patients for another 2 weeks to see what happens to them after reintroduction of food. Because we wanted to see how whether symptoms that improve, and then when we introduce food, whether symptoms starts to worsen. Which, interesting enough, some of the symptoms continue to get better. In retrospect, if we knew that, we would have continued the follow-up way longer. Because the common follow-up after an intervention in IBS world is about 2 weeks. So that's what we did. In this scenario, we should have done longer, but on the next study, we're going to do longer. Now, at each of these time points, patients provided stool. And we looked at this stool before the mBiota, after mBiota, and then 2 weeks after. On top of it, every day, patients, when they woke up, they blew into these tiny tubes, and we measured the methane levels in that breath. So number one, that we saw that during the elemental diet treatment, within 5 days, actually, the methane levels drastically dropped, which is actually faster than antibiotics. Which number one, it tells you how powerful diet can be. And number two is that, yes, we can develop things other than antibiotics to treat this. That's very sort of, that's the ultimate goal, right? So at the end, to stay away from empiric antibiotic for patients. But also we followed patients to see what happens to the methane all throughout. So what we did is that we correlated the amount of methanogens present in the stool with the methane in these breath tests, and they correlated, right? So because one thing that we weren't sure is that, okay, we're decreasing the methane production drastically by elemental diet. Is it because, well, they didn't have substrate to produce methane, so they're like, okay, I'm going to sleep until next time that I see food? And that turned out not to be the case, because we looked at the methanogens, and they're in fact actually decreasing. The load is decreasing, because even if they're sleeping, they're in dormancy, we still pick them up, right, based on genetic markers of these organisms. No, and in fact, actually, we saw that actually they're going back to the original state. Now, how does this happen? Two scenarios. The one scenario is that, well, we're just essentially decreasing it. They're just dying because of the elemental diet has some components that helps you in terms of almost suppressing of the growth. For example, MCT oils are known to decrease the growth of some of the bacteria and archaea. So maybe that's it. But I think it's the other way around. It's actually it's promoting the healthy growth of gut microbiome, and that healthy growth of microbiome and goes back and tells the archaea, hey, you have no room to be here. You should get out, right? And essentially that's factory setting gut microbiome now getting rid of the weed itself. So that's how it is. The reason why I say that, because the other changes that we saw in the stool microbiome is very similar to post-hibernation animals. Believe it or not, there are some researchers working on animals who hibernate and their microbiome, right? So they go collect stool from that hungry bear that just woke up after 6 months. This study was done in Sweden or Norway. And they looked at the gut microbiome of that animal, and it actually was, not surprisingly, very healthy gut microbiome, right? But the changes that we saw after mBiota was actually kind of similar to changes that we saw in those animals post hibernation, which is essentially complete reset of the gut, right? Because they're not eating, right? Because one thing that is very important for the gut microbiome, every day in our gut, the lining and epithelium sloughs, right, on a constant basis, right? Almost half a pound of your gut lumen sloughs and falls into your gut, right? So even if you're not eating at all, there is some food that goes through in the form of your own flesh going through, right? Uh, the beauty of that is that our normal native gut microbiome survives on that, thrives on that, but the invasive bacteria, the overgrown bacteria and archaea, can't survive on that. They need food, right? So when that phenomenon happens, whether through intermittent fasting, whether through hibernation, whether through elemental diet, native bacteria can survive, the invasive bacteria dies. And that native bacteria that grows back in even further pushes out the overgrown bacteria because that's their preferable environment now, right? So that's the beauty of it. Now, if you continue overeating like that bear that is supposed to do, because now they eat everything in their path, right? Pre-hibernation gut microbiome is not necessarily that healthy. And in fact, that they have put the poop of a pre-hibernation bear into mice, and mice get fat and unhealthy. And post-hibernation poop, they put it in mice and they get fit. Well, bears have to do that. So this cycle happens, and I think that's what we're triggering. And this is where I think like elemental diet now and mBiota in this scenario and intermittent fasting and hibernation all of a sudden are linking up for the gut microbiome health.
You know, that is so fascinating. I think most of us had thought the mechanism with elemental diet was that it just starved the overgrown microbes to death.
Yes.
But this is a whole different viewpoint. I'm loving it.
Yes. So no, so we were expecting complete, like, you know, complete suppression of bacteria and archaea post elemental diet. That was not the case at all. In fact, actually, the breath testing didn't completely become flat. It switched from, for example, methane dropped, obviously, all throughout the test. But the peak of the hydrogen in SIBO patients didn't completely go away. It's actually shifted towards the colon, which is the normal, right? So if it was about only starvation and wiping them out, no, that was not the case. You wouldn't have seen the colonic peak. We did see the colonic peak. So it's essentially switching a small intestinal overgrown bacterial picture to a normal colonic fermenting bacteria where they're supposed to be pictured. So it's kind of resets the gut rather than wiping it out. Yeah, I know. All throughout the years, in the last 20 years, we thought we were wiping them out. That was not the case, which is very fascinating. And we're seeing it in the stool as well, not just the breath test.
Yeah, and better than we could have hoped for. This is excellent.
Yes,
Like,
yes.
So now we know a method that can truly help dysbiosis, even whether it's SIBO, EMO, ESO, or something else even.
Absolutely. So this is the thing, right? So the SIBO and EMO are just two subcategories, right? So the whole dysbiosis, if you think about it, yes, can be like have an intervention that can sort of reset the gut. So that's potentially that can happen, right? For example, in the past, we didn't know intermittent fasting, but I mean, how long can you do intermittent fasting forever? You can't do that, right? But and also intermittent fasting, because the cycles of sloughing of the gut is about 5 days, right? The lining of the gut it takes 5 days, and it doesn't happen at each segment all the time, right? So you need 1.5 cycles, about 8 days. That's the magic number to reset the gut, at least. So that's what we saw. For example, that's probably where you get a reset of your gut.
But you can't do it for just 8 days.
Well, yeah. Well, I mean, technically you can. So that's the minimum that you should do to get that reset for sure. But the thing is that for intermittent fasting, well, you can't fast for 8 days, right? So
Right.
this is kind of
Right. No, I'm just talking about the mBiota.
yeah. So for mBiota, 8 days potentially is the magic number. So we are planning hopefully to do another study in healthy individuals to test that timeline to see, okay, when is the point that you see that beautiful gut reset and 8 days based on the preliminary data is probably the time, but we'll check it.
And also you saw a reduction of visceral fat too.
Absolutely. So that's actually, so that's one of the things that we looked at when we looked at, okay, how many days is enough? Because we checked in some of the subjects almost every day, we checked the visceral fat, right? It was tedious when we did it, but looked like the visceral fat, because, in total, at the end, about 11% visceral fat loss was seen. Almost 10% of 10% loss happened within the first 8 days, right? And then the other 6 days was just 1%. So that shows that goes like this. It's not like continuous like that. It was almost exponential. So that was one of the time points that popped up, that the 8 days might be the magic number.
It's interesting because, the original study that Mark and team did on elemental diet, some folks didn't clear the SIBO at 14 days. And then they went on to 21 days. And we do see this clinically. Some people do
Right.
need longer. How does that fit into this? Because I wouldn't want people to automatically think, oh, I only need 8 days and that's
Right.
it. We do see.
That's what I'm sitting here thinking.
Yes.
Yeah.
So and I was contemplating about that, and I think the answer is how much elemental diets come along. If you think about it, Y1X Plus, the formulation goes back to late 80s. So it was just Y1X in 70s and all the way to mid 80s, and then Y1X Plus came in, and it hasn't been updated yet, right?
Yeah.
And that study was done with Y1X Plus. So if you look at, for example, Y1X Plus, it has LCT oil. It has, so it's things that modern elemental diets don't necessarily need to have it. The technology on purifying amino acids have drastically changed. So that's another sort of important thing. The purifying MCT oils have drastically changed. So now we use MCT oils in elemental diet. So Y1X is not necessarily the same as mBiota. So maybe that's why we had to go longer with a Y1X as opposed to the modern elemental diets such as mBiota that seems to do the trick faster than that. I mean, there was actually a recent study again with Y1X. It's not just Mark's study that was done by the Chicago group, and this was done in eosinophilic gastrointestinal disorders. These are EGIT patients, and they had to do 6 weeks of it to see response. 6 weeks exclusive elemental diet. I mean, that's challenging, but I think 15 patients were able to finish it. So yeah, so that's the thing. So the modern elemental diets, like mBiota, are another beast clearly. As you compare it to the first generation of elemental diets, right? The Y1X versus Y1X Plus. Y1X Plus was like a huge revolution, but it hasn't changed in the last 2.5 decades. Yeah, more 3 decades. Yeah.
And in mBiota, the MCT oil is just built into the formula, right?
Yes.
You don't have to add it. So that's really nice.
Yes.
That's really nice. Yeah. Go ahead,
So
Dr. Siebecker. I know you're ready.
Oh yeah, it's
Yeah.
great. On this subject, clinical question. So many people get a side effect of bloating when they do elemental diet, even including mBiota. Any thoughts on that?
Yes. So one of them is actually MCT oil. So MCT oil, one of the first side effects, because we're not used to, our body is not used to get MCT oil. The majority of the fat that we're having in like regular food and all, the majority of them are long chain triglycerides, right? So, but if you have only MCT oil, MCT oils are relatively heavy. So bloating actually comes with it. It takes a few days for your stomach to like, oh, okay, I can tolerate this. So not surprisingly, you can feel that heaviness with it at the beginning. So that's why I tell my patients to sip it slowly and tolerate it that way. So hopefully that bloating sort of goes away. But just like any other interventions with tube feedings as well, there's always a subgroup of patients that no matter what tube feed that we use, they can't tolerate it. Now, whether it's because of the consistency, it's because of the osmolality, different components of tube feeds as opposed to solid food that they can't tolerate it. So that's a known phenomenon. There are some patients that unfortunately can't tolerate it fully, but sipping slowly does help in some.
Very helpful. Go ahead, Shivan.
The flavors, there's an orange flavor. And what's the other flavor, the original flavor? What is that flavor?
So that one that tastes a little bit like, it's very mild, but it tastes a little bit of it, maybe a hint of coconut, maybe a hint of vanilla. So that's that. I mean,
I
done it
had
myself.
one.
So yeah, so that's my favorite, and I tolerate it, no problem. Yeah.
The vanilla, the original flavor.
Yeah, the original.
Yeah.
Yeah.
Okay, just one more question related to this. And it's not even directly about elemental diet, but I just noted in this study a comment that, not everybody who showed methane on breath, too much methane on breath, was there M. smithii found in stool. And I was just wondering, why is that? Why do some people with positive methane, we don't see the M. smithii in stool?
We're checking that. So this was done with 16S, which is so all the microorganisms, they have this part of their DNA that is preserved throughout evolution. And they look like barcode. Essentially, it's like a barcode. And we scan that barcode to say that do you exist or not? But that depends on that part is preserved in the stool and it's not broken out. So there is a sampling error. There's always sampling error in that sort of technique because sometimes that piece of DNA has broken to a level that you can't find it, right? So there's always that false negativity because just the technology is that way. Now we're doing shotgun on the next level that doesn't just look at that the barcode. It looks at all pieces of DNA that it picks up. Obviously, it needs way more sort of processing power, sort of, and cloud-based sort of analysis to break this down to figure out how to do this. A supercomputer even 20 years ago would have taken like a year to break the data that we these days we do over a day. So technology is improving dramatically to look at that data. So in part, to answer your question, Allison, is the shortfall and shortcoming of the test itself assessment. It's not that it doesn't exist. We failed to detect it. And hopefully with shotgun, we will answer that as well. And another thing is always we have talked about, right? Stool is a little bit of a tricky sort of medium to deal with, right? Assuming that stool is a homogeneous sample like blood, that, okay, my glucose is 85 in this blood. Now my glucose everywhere is 85. That's probably true with some minor variation. But when I take a stool sample, that doesn't mean that that's like a small piece of stool is representative of the whole colon, right? So that's there is in part related to sampling error as for stool as itself being a poor medium.
Okay, thank you.
Yeah.
Now coming to testing, I know you had like 3 abstracts out in DDW about testing, and we could talk about any of them. They're all so interesting, but I guess I just wanted to ask you, I know about the classic debate. There's been this debate for so long about glucose versus lactulose, and that was one of the tests that came out. Just to hear your comments on, you know, because we've all, you and I and Dr. Pimentel preferred lactulose,
Yeah.
researchers prefer glucose, etc. So
Right. So I guess what we looked at in over 6,000 subjects, and these subjects were spread all over the 50 states, right? And these were not patients coming into tertiary centers or quaternary centers or academic centers. These are patients all over the country. So there are a good sample of the whole country. So we had, and patients were doing the breath test at home while doing, this was with TrioSmart, while filling out their questionnaire. So exactly the symptoms that they had at that moment, right? So what we looked at is that, yes, glucose and lactulose do pick up a SIBO, but lactulose with a much higher rate. So now the debate becomes those extra ones that lactulose is picking up, are they mostly false positive or not? And what we looked at is that the glucose picks up, yes, the patients with a SIBO, but those are SIBOs with severe diarrhea. These are like severe cases or severe bloating or severe abdominal discomfort, very severe cases, right? So that kind of tells you that possibly glucose only picks up the severe cases as opposed to lactulose picking up the moderate and severe and maybe some of the mild cases. So looks like it's the difference between glucose and lactulose is more because of more false negatives of the glucose rather than more false positives of the lactulose. So it depends what you want to answer in your clinical practice. If you want a very specific test, well, glucose is more specific, but if you want a sensitive test that you don't want to miss, lactulose is, based on this study, is the way to go.
thank you. That's like the hugest debate, and so many particularly practitioners get confused because they'll read in the literature, studies will skew towards glucose, but it's exactly that question. As docs, we're trying to find patients that we need to help, right? So lactulose is the better. And on this note with testing, any updates on best practices for those patients who are on like semaglutide, like the GLP-1, GIP drugs? Any change in what you're doing? I know it's hard to test these people. I think the last recommendation was to wait a week off the medicine, but what do you have to say on this?
Yeah, so I mean, just remember the GLP-1s have a very long half-life, 135 hours, essentially a week. And it takes 4 half-life to get out of your system. So a GLP-1 is not going to get out of your system for 4 to 5 weeks, right? So even if it's one injection. So and that affects your the movement of the gut and how it makes it more stagnant, right? And now this has a lot of benefits. It's weight loss, improvement in fat percentage, you know, the cardiovascular the risk decreases because of the weight loss and all. But obviously it affects the motility of the gut and increases the chance of dysbiosis and SIBO. It's very challenging to know, you know, because telling the patient, oh, you're on GLP-1, let's wait like 5 weeks off of GLP-1, don't do your injection, and then come back. I was like, well, okay, my sugar is going to be under control. I'm going to gain all the weight that I've lost. What do you want me to do? So at this point, we're not implementing any sort of limitations. We just do it for the breath test, understanding that it's a little bit murky to interpret the results, right? Because lactulose may not even make it to the small bowel. So it makes it a little bit tough to diagnose. But the good news is that the new generation of GLP and GIP sort of drugs like tirzepatide or Mounjaro, they do not have the drastic effect that only GLP-1s have, like Ozempic, right? And that has been shown even on head-to-head clinical trials of these two, tirzepatide versus semaglutide, or in other words, Mounjaro versus Ozempic, that Mounjaro has less GI side effect. And the newer generation of these medications are going to target 1, 2, or 3 receptors. So to modulate that drastic effect that GLP-1 has on the gut. So I think in 5 years, the drastic effect that they have on motility with the newer, more modern molecules that will come to the market would not be as bad as now. So hopefully this is a transient blip of a problem that we have, right? Because, let's face it, in reality, what these medications are doing in terms of decreasing the rate of obesity, improving cardiovascular health is very drastic, and it's helping our society as a whole. But they do come with their own set of complications that we need to deal with. Yeah.
Thank you.
Thank you so much, Dr. Rezaie.
Thank you so much. I know that our time is up, but I really, both of us, all of us, communities and the YouTube universe and beyond, really appreciate all you're doing. Thank you for taking the time to communicate this to us. And we will look forward to more breaking news.
All righty. Thank you so much. Thanks for having me, guys.
Oh, we love it. Thank you.